Okay, let's unpack this. We're dedicating this entire deep dive to achieving, well, hopefully something close to absolute mastery over diabetes mellitus. We're talking the pathology, the really complex signaling of insulin, and the comprehensive pharmacology of pretty much every drug used to treat it. Our sources are incredibly detailed. They treat this not just as, a clinical problem, but almost like a masterpiece of biochemical dysregulation gone wrong. So if you need to understand the structural shifts that define modern diabetic care, things like the K+ ATP channel mechanisms, right up to the newest ultra-long acting analogues, well, this is where we kick things off.
That's exactly the mission. And you're right, we absolutely cannot view diabetes mellitus or DM just as high blood sugar. That's really just the symptom, isn't it? Not the whole picture. DM is fundamentally this widespread pathological disorder. It touches nearly every system in the body. And appreciating that complexity, the sheer scale of the potential damage, is absolutely key to understanding why the therapy often needs to be so, well, intense.
Okay, let's nail down the hard definitions first then. When does high sugar actually become official DM? And what's the sort of catastrophic cascade that follows once it does?
Right. So the diagnosis hinges on persistent, measurable hyperglycemia, high blood sugar that sticks around. The two core markers we look for are a fasting plasma glucose level of 126 milligrams per deciliter or higher, or alternatively, a reading of 200 milligrams per deciliter or higher, specifically 2 hours after the patient drinks a standard 75-gram oral glucose load. Once you see those levels sustain, the pathological hallmarks start to emerge. We see glycosuria, that's sugar literally spilling into the urine. Then there's hyperlipidemia, abnormal blood fats, a negative nitrogen balance, which tells you protein is being broken down faster than it's built. And sometimes ketonemia, ketone bodies building up in the blood.
And the real danger, the thing we're always fighting against, is that long-term systemic destruction, especially the vasculature, the blood vessels. It just seems relentless.
It is relentless. The sources make it crystal clear. This is both a microvascular and a macrovascular catastrophe. We actually observe physical changes like thickening of the capillary basement membrane. There's an increase in the vessel wall matrix itself and sort of unchecked cellular proliferation. All of this leads to the narrowing of the vascular rumen, the space inside the vessel. Clinically, what does that mean? Well, it translates directly to accelerated atherosclerosis hardening of the arteries. It means glomerulosclerosis in the kidneys, which can lead to eventual kidney failure, retinopathy in the eyes, potentially leading to blindness, and neuropathy, nerve damage. And the severity, well, it really depends almost entirely on the duration and the level of control or lack of control over the hyperglycemia.
That kind of structural damage, it must have a clear molecular driver, right? It can't just be sugar physically damaging things. There have to be specific biochemical processes going haywire.
You're absolutely right. There are two main processes, both driven by that persistent high glucose environment. The first one is enhanced non-enzymatic glycosylation of tissue proteins. Basically, glucose starts sticking randomly to proteins all over the body, kind of like sticky paint, without needing an enzyme to make it happen. And this fundamentally alters the protein structure and, critically, its function. It happens everywhere.
Which is precisely why we use HbA1c as the gold standard index for long-term control, correct?
Absolutely spot on. HbA1c, or glycosylated hemoglobin, is the perfect metric because it measures exactly that process, the non-enzymatic sticking of glucose to hemoglobin inside red blood cells. Now, since a red blood cell lives for about 120 days, give or take, the HbA1c reading gives us this really reliable historical average of blood sugar levels over the preceding 2 to 3 months. It offers a much, much more accurate picture of metabolic control than, say, a single blood draw, which can be influenced by what someone ate just before or even manipulated.
Okay, so that's glycosylation. What's the second catastrophic pathway you mentioned?
That would be the sorbital pathway. You see, in certain tissues, particularly the nerves, the retina of the eye, and the kidneys, glucose can be metabolized into sorbitol, which is a sugar alcohol. Now, when glucose levels are chronically high, the enzyme that normally processes sorbitol further, aldose reductase, it just gets overwhelmed, saturated. This leads to a massive accumulation of sorbitol inside these cells. And this buildup causes osmotic stress and is strongly implicated as a major causative factor in diabetic pathology, especially neuropathy and retinopathy. It's like a secondary metabolic route that becomes a primary source of damage.
Okay, that's a solid foundation. Let's use that to differentiate between the two, well, really vastly different forms of the disease, because the entire therapeutic approach hinges on knowing if you're dealing with type 1 or type 2.
Indeed. Metabolically, they are worlds apart, even though both ultimately result in high blood glucose.
Let's start with type 1 DM. Historically, we called it insulin-dependent or juvenile onset. What's the root cause there?
Type 1 is defined by essentially the absolute destruction of the insulin-producing beta cells, the beta cells within the pancreatic islets. The overwhelming majority of these cases we classify as type 1A. These are autoimmune in origin. You can actually detect anti-beta cell antibodies in the blood actively destroying those cells. Then there's a smaller fraction, type 1B, which we call idiopathic. Here, the antibodies are absent, but the destruction still happens for reasons we don't fully understand yet. But the result is critical. Circulating insulin levels become low, or very, very low. This necessitates giving insulin from outside exogenous insulin. And these patients are highly susceptible to developing ketosis. Genetically, this type typically has a relatively low predisposition compared to type 2.
Right. Now, type 2 DM, this is the most prevalent form, accounting for, over 90% of cases, and usually with a later maturity onset. The pathology here is fundamentally different, isn't it?
It is, and it's complex. Type 2 has a very strong genetic predisposition, much higher than type 1. And unlike type 1, the beta cell mass, the number of insulin-producing cells, is generally preserved or maybe only moderately reduced. Insulin levels themselves can vary wildly. They might be low, they could be normal, or, and this often surprises people, they can even be high. Importantly, you don't find those anti-beta cell antibodies. The problem isn't primarily a lack of production capacity. It's more like a failure of communication and adequate response from the body.
And that communication failure seems to be twofold, right? What are the specific mechanisms of dysregulation that are going wrong?
That's really the core insight into understanding type 2. The first issue is impaired insulin secretion. The beta cells themselves might have an abnormality in their glucose sensor, their glucoreceptor, making them kind of sluggish. They might only wake up and release insulin when glucose concentrations are already higher than they should be. Or there might simply be a relative functional deficiency. They just can't keep up with the massive demand, especially in the face of resistance.
And that leads to the second, often dominant problem. Reduced peripheral sensitivity, insulin resistance.
Precisely. This is the other side of the coin. It means the target tissues, primarily the liver, skeletal muscle, and fat, are not responding properly to the insulin that is being secreted. We actually see what's called downregulation in these cells, essentially a reduction in the number of active insulin receptors on their surface. The signal is being sent, but the peripheral systems are effectively ignoring it, or at least not hearing it clearly.
It's really striking how closely this maps onto what we call the metabolic syndrome. You see so many individuals showing signs of this resistance long before they actually cross the diagnostic threshold for full-blown DM.
That's an absolutely essential observation for anyone in clinical practice, or just trying to understand population health. Our sources really emphasize this point. Many hypertensive patients, people with high blood pressure, are actually hyperinsulinemic, meaning their bodies are overproducing insulin, trying desperately to compensate for resistance, even while their blood glucose might still look normal or normoglycemic. And often, they also present with dyslipidemia, bad cholesterol profiles, hyperuricemia, high uric acid, and that characteristic abdominal obesity. This state of relative insulin resistance and the resulting chronic hyperinsulinemia, they are strongly implicated in causing angiopathy, the vascular damage we talked about earlier. The damage can actually start years before the glucose numbers officially flag diabetes, simply because the sheer metabolic effort required to keep those numbers normal is straining the system, especially the blood vessels.
Just for completeness, maybe we should briefly touch on the rarer forms, the ones that sometimes confuse the clinical picture a bit.
Certainly. These often get grouped under the umbrella of type 3 diabetes. This includes specific genetic defects like MODY. That stands for maturity onset diabetes of the young. It's an important clinical nugget because MODY is often misdiagnosed as type 2, given its later onset, but it has a very specific, often autosomal dominant genetic inheritance pattern. Type 3 also includes diabetes arising from other endocrine disorders or after pancreatectomy, removal of the pancreas. And then there's type 4, which is specifically gestational diabetes mellitus, or GDM, occurring during pregnancy.
Okay, so if insulin resistance is really the core problem in type 2, we absolutely need to understand the molecule it's resisting. Let's dive deep into insulin itself, the central hormone here. It feels like it's impossible to really master the therapeutics without understanding how it's made, how it's released, and its whole signaling cascade.
Absolutely. And, we often forget the sheer historical gravity here. The discovery back in 1921 by Banting and Best, showing the hypoglycemic action of pancreatic extract, that was an instant life-saving revolution. Overnight, Type 1 diabetes went from a death sentence to a manageable condition, and the structure itself, fully defined later, it's really a marvel of molecular engineering.
What does that structure tell us? What are the key features?
Well, it's actually a relatively small polypeptide hormone made of 51 amino acids. It's split into two chains. The A chain has 21 amino acids and the B chain has 30. These two chains are held together by two crucial disulfide bonds, with a third disulfide bond within the A chain itself. This intricate 3D structure is absolutely critical for its biological function. Its molecular weight is roughly 6,000 Daltons. And interestingly, when they compared it across species early on, they found that pork insulin was the most similar, or homologous, to human insulin. It differs by only one amino acid, whereas beef insulin differs by 3. This similarity greatly influenced early insulin production techniques before recombinant DNA technology really took over.
Walk us through its synthesis inside that beta cell. It's not just made as insulin, is it? It's a precise multi-step process.
That's right. It's a classic example of post-translational processing. It actually begins as a single longer polypeptide chain called preproinsulin, which is 110 amino acids long. The first step involves cleaving off a 24 amino acid signal sequence as it enters the endoplasmic reticulum, forming proinsulin. Then, within the Golgi apparatus and subsequent storage granules, proinsulin is processed further. Specific enzymes cut it, releasing the mature, active 51 amino acid insulin molecule, and also a 35 amino acid fragment called the connecting peptide, or C-peptide. Both mature insulin and the C-peptide are stored together in secretory granules and are secreted together in equimolar amounts, meaning for every molecule of insulin released, one molecule of C-peptide is also released. This is why measuring C-peptide levels in the blood is such a valuable diagnostic tool. It tells us exactly how much endogenous insulin the patient's own pancreas is producing, even if they're receiving exogenous insulin injections.
Okay, let's talk about the regulation of its release. This seems like a masterclass in biological feedback loops. What's the pancreas doing constantly, even when we're not eating?
Right. Even in the fasting state, there's a constant low-level basal secretion of insulin, maybe around 1 unit per hour. This maintains background fuel homeostasis, but the real action happens after a meal. The regulation then involves this intricate interplay of chemical, hormonal, and neural mechanisms. By far, the most critical trigger is the chemical sensing of glucose itself by the beta cell.
And the mechanism for that glucose sensing, that's foundational, isn't it? Because it's precisely the target of the oldest class of oral antidiabetic drugs. Can you detail the mechanics of that K plus ATP channel?
Absolutely. The theta cell volar acts as a remarkably sophisticated glucose sensor. Glucose enters the cell, primarily through the GLUT1 transporter in humans. Once inside, it's immediately phosphorylated by the enzyme glucokinase. This is a key rate-limiting step, trapping glucose inside. The subsequent metabolism of this glucose rapidly generates ATP, increasing the ATP to ADP ratio within the cell. Now, this ATP molecule acts as the direct signal. It binds to and inhibits a specific channel in the cell membrane called the ATP-sensitive potassium channel, or the K plus ATP channel. Normally, this channel allows potassium ions to flow out, keeping the cell membrane polarized. When ATP closes it, potassium outflow decreases. This causes the cell membrane to depolarize slightly. This partial depolarization is enough to open nearby voltage-sensitive calcium channels. Calcium ions then rush into the cell, dramatically increasing the intracellular calcium concentration. And it's this surge in intracellular calcium that triggers the final step: the exocytotic fusion of the stored insulin granules with the cell membrane, releasing their contents, insulin and C-peptide, into the bloodstream.
Wow, that sequence, glucose in, ATP up, K plus block, K2 plus in, insulin out, that's such an elegant feedback loop. And the timing of the release, it isn't just a steady stream, is it? There's a distinct biphasic response.
Yes, that's another crucial feature. When the beta cell is hit with a sharp glucose stimulus, like after a meal starts, there's an immediate, brief first phase of insulin output. This happens within the first 2 minutes or so. This first phase represents the release of preformed, readily available insulin granules that are docked right near the cell membrane. This is then followed by a more delayed but sustained second phase of insulin release. This represents the continued synthesis and release of new insulin granules, as well as the mobilization of granules from a reserve pool. Interestingly, the loss or blunting of that rapid first phase insulin release is often one of the very earliest detectable signs of beta cell dysfunction, even in the pre-diabetic stage.
Okay, now here's where, for me, it's really interesting: the incretin effect. Why is swallowing glucose so much more powerful at stimulating insulin than getting it through an IV drip?
The incretin effect. It's fascinating. You're right, oral glucose is typically 2 to 4 times more potent at stimulating insulin release than an equivalent amount of glucose given intravenously. The reason is that the gut provides an anticipatory signal. When you ingest glucose or other nutrients, spitalized enteroendocrine cells in the lining of your gut release hormones known as incretins. The two main players are GLP-1, glucagon-like peptide 1, and GIP, glucose-dependent insulinotropic polypeptide. These hormones travel through the circulation, bind to specific receptors on the pancreatic beta cells, and essentially give them a heads up. Nutrients are coming. This does two things. It triggers an anticipatory insulin release even before blood glucose rises significantly, and it significantly enhances the beta cell sensitivity to glucose, primarily by boosting intracellular COMP levels. This system is so physiologically important that, as we'll discuss, modulating it pharmacologically has become a central therapeutic strategy in type 2 diabetes.
And layered on top of that, we also have the paracrine system, these tiny chemical dialogues happening right within the islets of Langerhans themselves.
Exactly. The islets are like little endocrine microorgans, and the different cell types within them are constantly talking to each other. You have the beta cells making insulin, the alpha cells making glucagon, and the delta cells making somatostatin. They all influence each other's secretion. Somatostatin generally acts as the brake, inhibiting the release of both insulin and glucagon. Conversely, glucagon, the counter-regulatory hormone, actually stimulates the release of both insulin and somatostatin. And insulin itself acts locally to inhibit glucagon secretion from the neighboring alpha cells. This helps maintain glucose homeostasis and prevents excessive glucose production by the liver. Furthermore, another hormone called amylin, which is co-secreted with insulin from the beta cells, also contributes to suppressing glucagon release, although it seems to act primarily via a central site in the brain.
And then, just to add another layer of complexity, the nervous system gets involved too.
Right. Neuromodulation provides another way to fine-tune insulin output based on the body's immediate needs or stress levels. Adrenergic sympathetic activation, like during a fight-or-flight response, primarily acts through alpha-22 receptors on the beta cells to decrease insulin release. This makes sense physiologically. You want to conserve glucose for the brain and muscles during stress. However, beta-22 adrenergic stimulation actually increases insulin release, and cholinergic stimulation via the vagus nerve, part of the parasympathetic rest and digest system, also enhances insulin secretion, primarily by increasing intracellular calcium through the IP3DAG signaling pathway. It's a beautifully complex regulatory network.
Okay, so once insulin is finally released into the bloodstream, it needs to exert its effects on target tissues. Let's transition into its mechanism of action. This involves that complex receptor tyrosine kinase, or RTK cascade.
Yes, the insulin receptor itself is the key. It's found on the surface of virtually every cell in the body, but it's particularly dense in the major insulin-responsive tissues: liver, fat, and muscle. Structurally, it's a heterotetrameric glycoprotein. That means it's made of 4 subunits linked together. There are 2 extracellular alpha subunits, which are responsible for actually binding the insulin hormone, and there are 2 transmembrane beta subunits that span the cell membrane. Crucially, the intracellular portion of these beta subunits possesses intrinsic tyrosine protein kinase activity.
So what happens the instant that insulin molecule binds to the alpha subunits?
Binding of insulin to the alpha subunits induces an immediate conformational change in the entire receptor complex. This causes the receptor units to aggregate or cluster together, and this clustering activates the dormant tyrosine kinase activity of the intracellular domains of the beta subunits. The first thing they do is phosphorylate each other on specific tyrosine residues. This is a critical step called autophosphorylation. This autophosphorylation fully activates the receptor's catalytic site, turning it into a highly active kinase. It then proceeds to phosphorylate various intracellular substrate proteins, again on their tyrosine residues. The most important initial targets are the aptly named insulin receptor substrate proteins, IRS1, IRS2, and others.
It really sounds like a biological amplifier circuit. The phosphorylation of those IRS proteins then kicks off the downstream signal transmission, right?
Exactly. The phosphorylated IRS proteins act like docking platforms. They recruit and activate a whole host of other signaling molecules, launching 2 primary intracellular signaling arms or pathways. The first is the PI3 kinase, phosphatidylinositol 3 kinase pathway. This is generally responsible for mediating most of insulin's rapid metabolic effects, like glucose transport and glycogen synthesis. It does this partly by generating the second messenger lipid, PIP3. The second major arm is the MAP kinase, mitogen-activated protein kinase pathway. This pathway is more generally associated with insulin's longer-term effects on gene expression, cell growth, and differentiation.
Let's focus on that key metabolic outcome, the one everyone associates with insulin, the GLUT4 translocation. This seems like the absolute difference between life and death for muscle and fat cells needing glucose.
It's certainly the most visible and perhaps the most critical rapid effect of insulin in peripheral tissues. Activation of that PI3 kinase pathway and the subsequent generation of PIP3 and other downstream signals triggers the movement or translocation of specialized glucose transporters called GLUT4. Normally, GLUT4 resides in intracellular vesicles within the cytoplasm of skeletal muscle and adipose cells. Insulin signaling causes these GLUT4-containing vesicles to rapidly move to and fuse with the plasma membrane. Once inserted into the membrane, these GLUT4 transporters dramatically increase the cell's capacity to take up glucose from the bloodstream, facilitating its entry down its concentration gradient. This entire process is remarkably fast, occurring within seconds to minutes of insulin binding.
But insulin's actions don't just stop there at getting glucose into cells, right? It has intermediate and even long-term effects as well.
That's right. It's a hormone that works on multiple timescales. The intermediate actions, which might take hours, involve regulating the activity and synthesis of key metabolic enzymes. For instance, insulin increases the production of glucokinase in the liver, the enzyme that traps glucose. The long-term effects, often mediated partly by that MAP kinases pathway I mentioned, involve influencing gene transcription to promote things like cell multiplication and differentiation. It really impacts the overall metabolic state and health of tissues over days, weeks, and months.
Finally, for this part, what's the fate of this powerhouse molecule in the body? How long does it stick around?
Surprisingly, insulin has a very short plasma half-life, typically only around 5 to 9 minutes. This short duration means that its levels can be rapidly adjusted, requiring constant synthesis and secretion by the pancreas to maintain effects. It's primarily metabolized and inactivated in two main organs, the liver and the kidneys. The liver is particularly important because due to the portal circulation carrying blood directly from the pancreas, it's exposed to much higher insulin concentrations than the rest of the body, maybe 4 to 8 times higher. In fact, nearly half of the insulin secreted by the pancreas is extracted and degraded by the liver in its first passage through it. This high first-pass extraction is critical for the liver's role in regulating glucose output. The kidneys also play a significant role in clearing insulin from the circulation, as do muscles to some extent.
Okay, connecting that relatively short-lived molecular signal to the grand physiological picture, let's look at the detailed metabolic actions. You called insulin the ultimate anabolic hormone, the hormone of storage.
Absolutely. Its primary directive, especially after a meal, is to deal with the influx of fuel and promote energy storage for later use. So, regarding glucose transport and utilization, while some tissues like the brain, red blood cells, and importantly the liver, using GLUT2, are generally considered insulin independent for glucose uptake, their transporters are always present. Skeletal muscle and fat tissue are highly insulin dependent. They rely almost completely on that insulin-stimulated GLUT4 translocation to get glucose inside.
And once the glucose is inside, how does insulin actively promote its storage, particularly its glycogen?
Insulin orchestrates glycogen storage very effectively. As we mentioned, it enhances glucokinase production in the liver, which is the crucial first step for trapping and utilizing glucose. Furthermore, it directly stimulates the enzyme glycogen synthase, the enzyme that actually builds the glycogen polymer chains from glucose units. And simultaneously, it inhibits the enzyme glycogen phosphorylase, which is responsible for breaking down glycogen. This dual action stimulating synthesis while inhibiting breakdown dramatically increases glycogen accumulation and storage capacity, primarily in the liver and muscles, but also to some extent in fat.
Moving on to protein and nitrogen balance. How does insulin prevent muscle wasting and promote growth?
It's fundamentally anti-catabolic regarding protein. In the liver, it actively inhibits gluconeogenesis, the process of making new glucose from amino acids and other precursors. It does this partly through gene-mediated mechanisms, specifically decreasing the synthesis of key enzymes like phosphenol pyruvate carboxykinase, PPCK. Critically, in peripheral tissues like muscle, it promotes the entry of amino acids into the cells and directly stimulates the machinery of protein synthesis. At the same time, it inhibits protein breakdown, or proteolysis. So when insulin is deficient, this entire balance flips dramatically. Protein breakdown accelerates, amino acids are released from muscle, they flood the liver where they're converted into glucose, further worsening hyperglycemia, and urea, leading to that characteristic negative nitrogen balance and muscle wasting you see in uncontrolled diabetes.
And perhaps the most dramatic consequence of this unchecked catabolism is in lipid metabolism, which leads directly to the emergency state of diabetic ketoacidosis, DKA. Can you detail that specific pathway?
Yes. DKA is the extreme endpoint of insulin deficiency's effect on fat. Insulin is normally a powerful inhibitor of lipolysis, the breakdown of stored fat, triglycerides, in adipose tissue. It also promotes triglyceride synthesis for storage. When insulin is severely deficient, like in untreated type 1 diabetes, this inhibition is lost. There's an uncontrolled surge of counter-regulatory hormones like glucagon, catecholamines, cortisol that are lipolytic. This leads to massive breakdown of fat stores, releasing huge amounts of free fatty acids, FFAs, and glycerol into the bloodstream. These FFAs flood the liver, which takes them up and processes them through beta oxidation into acetyl-CoA.
Normally, the liver would use that acetyl-CoA, but if there's just too much.
Exactly. In severe insulin deficiency, the liver's capacity to use acetyl-CoA for resynthesizing fatty acids or for energy production in the Krebs cycle is completely overwhelmed. Instead, the excess acetyl-CoA is dangerously diverted into an alternative pathway: ketogenesis, the production of ketone bodies. These are primarily acetone, acetoacetate, and beta-hydroxybutyrate. When the rate of ketone production by the liver drastically exceeds the body's ability to utilize them as fuel, mainly by muscle and brain, they accumulate in the blood ketonemia and spill into the urine ketonuria. Because two of these ketone bodies, acetoacetate and beta-hydroxybutyrate, are acidic, their massive accumulation leads to the severe metabolic acidosis that is the hallmark and the primary danger of DKA. Just as a side note, insulin also has a beneficial effect on lipid clearance. It enhances the removal of triglyceride-rich lipoproteins like VLDL and chylomicrons from the blood by accelerating the transcription of the enzyme lipoprotein lipase in vascular endothelium.
Okay, having firmly established just how critical insulin is, let's finally discuss its therapeutic application. The evolution of the insulin preparations themselves is a fascinating story of molecular engineering, all aimed at better mimicking that natural physiological release profile.
It really has been an incredible journey, pharmacologically speaking. We started, as mentioned, with relatively crude animal extracts, beef and pork insulin. These worked, but often caused allergic reactions due to impurities. Then came a major step forward with highly purified monocomponent or MC insulins, primarily pork, which contain less than 10 parts per million of proinsulin contaminants. This greatly reduced antigenicity. Today, we rely heavily on recombinant human insulins produced using biotechnology, often denoted PROB for produced by recombinant bacteria or PEER for recombinant yeast, and increasingly we use the even more sophisticated insulin analogues where the amino acid sequence has been deliberately modified. Although highly purified pork MC insulin was very effective and only minimally different from human, recombinant human insulin is now generally the standard. That said, clear clinical superiority over purified MC pork insulin hasn't always been definitively demonstrated, unless, of course, a patient has a specific allergy.
And those analogs, they are really the key to modern precision control, aren't they? Because they allow us to deliberately adjust the pharmacokinetic profile, basically, how fast they start working and how long they last. Let's categorize the main types based on that duration.
Exactly. We can classify them primarily by their duration of action, which is almost entirely determined by how quickly they get absorbed from the subcutaneous injection site into the bloodstream. This, in turn, depends on how quickly they dissociate from their injected form, often hexamers, into absorbable monomers.
Okay, starting with the speed demons, the rapid-acting analogs. We're talking Lispro, Aspart, and Glucagon. What specific structural change gives them that incredible speed compared to regular human insulin?
Their speed comes from clever, specific amino acid modifications designed to destabilize the natural tendency of insulin molecules to clump together into hexamers, groups of 6, around zinc ions after injection. For instance, in insulin Lispro, the amino acids proline and lysine at positions B28 and B29 of the B chain are reversed compared to human insulin. In regular human insulin, these two amino acids in their normal positions facilitate the formation of those stable zinc-coordinated hexamers in the subcutaneous tissue. These hexamers have to slowly break apart into dimers and then monomers before they can be absorbed. By reversing them, or making similar changes in Aspart and Glucagon, the analogs have a much lower tendency to self-associate. They dissociate into absorbable monomers almost immediately upon injection. This allows for very quick absorption, an onset of action with as maybe 10-20 minutes, 0.2 to 0.4 hours, and a sharp, well-defined peak effect. Clinically, this means they can be injected just 0 to 20 minutes before starting a meal, offering vastly superior control over the postprandial after-meal glucose spike compared to older insulins.
Now, contrast that sharply with the older short-acting insulin, which we usually just call regular or soluble insulin.
Right, regular insulin is chemically unmodified human insulin. It's dissolved in a buffered solution, usually containing zinc to improve stability. When you inject it subcutaneously, it forms those classic zinc-stabilized hexamers we just talked about. These hexamers have to slowly dissociate before absorption can occur. This results in a significantly delayed onset of action, typically 30 to 60 minutes, 0.5 to 1 hour, and a peak effect that occurs much later, usually 2 to 3 hours after injection. This delay creates a significant clinical mismatch. If you inject regular insulin just before eating, you often get early postprandial hyperglycemia because the insulin hasn't kicked in yet. Then you might run into late postprandial hypoglycemia a few hours later because the insulin peaks long after the meal's glucose has been absorbed. Optimally, regular insulin requires injection about 45 to 60 minutes before the meal to align its peak better with food absorption, which is often inconvenient. One absolutely essential detail, though. Regular insulin is the only insulin preparation that is suitable for intravenous IV injection, like in treating DKA or during surgery. The analogues are generally not used IV.
Okay, moving on to the intermediate acting types, NPH, and the older lente insulins. These were designed primarily for providing some background or basal coverage.
That was the goal, yes. These preparations were deliberately made less soluble to significantly slow down their absorption from the injection site. NPH stands for neutral protamine hagedorn, also called isophane insulin. Here, the insulin is complexed with protamine, which is a basic protein derived from fish sperm. This complex precipitates out, forming crystals that dissolve slowly. The older lente insulins, semilente, lente, ultralente, use precipitation with excess zinc ions at neutral pH to create suspensions with varying crystal sizes and durations. Lente itself was a mix of smaller, semilente, and larger, ultralente crystals. These intermediate types generally provide an onset of action around 1 to 2 hours, a peak effect somewhere between 8 and 10 hours, and a duration of action lasting roughly 12 to 20 hours. Traditionally, they were the backbone of simpler regimens, especially the split-mixed regimen, where they are often combined in the same syringe with regular insulin in fixed ratios, like the common 70% NPH, 30% regular mix.
And finally, we reach the modern long-acting or basal analogues. These are engineered to provide smooth, relatively peakless background insulin coverage over a full day. Glargine is perhaps the classic example here.
Glargine, brand name Lantus for example, achieves its long duration, typically up to 24 hours, through a clever pH manipulation strategy. It's formulated in a clear acidic solution around pH 4.0. When this acidic solution is injected into the body's neutral subcutaneous environment, pH 7.4, the glargine molecule immediately precipitates out of solution. It forms these tiny microprecipitates, creating a depot from which the insulin monomers are slowly and continuously released into the circulation over many hours. This mechanism is how it achieves its characteristic smooth, relatively peakless profile, which is ideal for mimicking the body's natural basal insulin secretion. But a crucial clinical point we absolutely must emphasize. Because glargine is formulated at an acidic pH, it cannot be mixed in the same syringe with any other insulin preparation, which are typically formulated at a neutral or near neutral pH. Mixing them would cause the glargine to precipitate immediately in the syringe, altering its profile and potentially the profile of the other insulin too.
Interesting. What about the other major long-acting players, Dithemir and the newer Diabetic? How do they achieve similar or even longer durations using different tricks?
Diabetic, Levemir, uses a different molecular modification strategy. A fatty acid radical, specifically myristoyl acid, is attached to the insulin molecule. This fatty acid chain allows the detemir molecule to reversibly bind to albumin, both in the plasma and, importantly, within the subcutaneous tissue depot itself. This protein binding acts like a slow release mechanism. Insulin molecules gradually dissociate from albumin and get absorbed. This provides an action profile similar in smoothness to glargine, although its duration is often slightly shorter, frequently requiring twice-daily dosing in many patients to achieve true, consistent 24-hour basal coverage. Diabetic, Tresiba, is the newest and perhaps most sophisticated of the bunch. It's an ultra-long-acting analog. After subcutaneous injection, diabetic monomers self-assemble into long, stable multi-hexamer chains. This creates a subcutaneous depot from which insulin monomers slowly and very consistently dissociate over an extended period. This results in an incredibly flat, predictable, and consistent effect that lasts well beyond 24 hours, often around 40 hours or even longer. This ultra-long duration is highly effective at minimizing variability and, critically, reducing the risk of nocturnal hypoglycemia, which remains a major concern and fear for patients using basal insulins.
Okay, so with this arsenal of different insulin preparations, two major therapeutic regimens tend to dominate management, especially for type 1 diabetes and more advanced type 2 requiring insulin.
Broadly speaking, yes. The first is the older, simpler approach, the split-mixed regimen. This typically involves using a premix formulation, like that 70/30 NPH regular mix we mentioned, or mixing intermediate and short-acting insulins yourself. It's usually given twice daily, before breakfast and before the evening meal. While it has the advantage of reducing the total number of daily injections, usually just 2, it often provides rather inadequate glycemic coverage, particularly for the glucose rise that happens after lunch, and can sometimes lead to overnight hypoglycemia if the evening NPH dose peaks too strongly.
Right. And the second approach, considered the gold standard for achieving tight glycemic control, is the basal bolus regimen, sometimes called intensive insulin therapy.
Exactly. This regimen attempts to mimic the body's natural physiological insulin release pattern much more closely. It relies on 2 components. First, a basal insulin dose, typically provided by 1, or sometimes 2, daily injections of a long-acting analog like glargine, detamir, or degludec. This covers the background insulin needs between meals and overnight. Second, bolus doses of a rapid-acting analog, lispro, aspart, or glulisine, are injected immediately before each meal, usually 2 to 3 times a day. These boluses are calculated to cover the carbohydrate intake of that specific meal. This approach is certainly more demanding for the patient, requiring more injections, more frequent blood glucose monitoring, and careful carbohydrate counting. It's also generally more expensive due to the use of analogues. However, it consistently achieves the best glycemic results, getting patients closer to round-the-clock euglycemia, normal blood sugar, and offering much greater flexibility in meal timing and content.
Beyond just syringes and vials, delivery innovations have also made a big difference, constantly trying to improve convenience and precision for patients.
Definitely. Insulin pen devices have become ubiquitous. They offer much greater convenience and dosing accuracy compared to traditional vial and syringe methods, using pre-filled cartridges or disposable pens with simple dial-up dosing. Then, for even more sophisticated control, we have continuous subcutaneous insulin infusion, CSII systems, commonly known as insulin pumps. These are small, portable, computerized devices that deliver only regular, or more commonly now, a rapid-acting analog insulin through a tiny cannula inserted under the skin. They are programmed to deliver a low, continuous basal rate of insulin 24/7, which can often be adjusted for different times of day. The patient then manually delivers bolus doses through the pump before meals based on their blood sugar and planned carb intake. While pumps offer superb flexibility and potentially smoother control, they require strict patient adherence, intensive education on pump management, meticulous attention to infusion site care to prevent infections or blockages, and continuous wear. Interestingly, despite their sophistication, demonstrating definitive universal superiority in glycemic outcomes like HbA1c reduction over a well-executed basal bolus multiple daily injection MDI regimen hasn't always been consistently proven across all major studies, though patient satisfaction is often higher with pumps.
And then there's the really novel development of inhaled insulin Afrezza. It sounds almost like science fiction, but it's real, though it comes with specific limitations.
Afrezza is indeed a fascinating pharmaceutical marvel. It's a dry powder formulation of regular human insulin that's inhaled using a special device. It gets absorbed incredibly rapidly across the vast surface area of the lung alveoli directly into the bloodstream. This allows for a very, very rapid onset of action, even faster than the injected rapid analogs, typically within 10 to 15 minutes. It also has a relatively short duration, with the effect terminating around 3 hours. This profile makes it an excellent option purely for prandial control covering meals. It's not suitable for basal coverage. However, due to its pulmonary route of administration, it comes with significant caveats. It is strictly contraindicated in smokers and in patients with chronic lung diseases like COPD or asthma due to unpredictable absorption and potential lung effects. A common side effect reported is also a persistent non-productive cough, so while innovative, its use is somewhat niche.
Okay, let's pivot now to the clinical realities specifically, when things go dangerously wrong. We absolutely have to start with the most common and often the most immediate threat to a diabetic patient's well-being and sometimes life: hypoglycemia, or low blood sugar.
Hypoglycemia is, without doubt, the most serious frequent adverse reaction to insulin therapy, and also some oral medications, as we'll see. The common causes are pretty straightforward: taking an inadvertent larger dose of insulin than needed, missing or delaying a meal after taking insulin, or engaging in unusually vigorous or prolonged physical exercise without adjusting insulin or food intake. The symptoms are crucial for patients to recognize, and they generally fall into 2 categories. First, there are the symptoms triggered by the body's counter-regulatory sympathetic nervous system response, which serve as the early warning signs. These include things like sweating, palpitations or a racing heart, anxiety, and tremor or shakiness.
And the second category involves the direct neurological consequences of the brain being starved of glucose.
Exactly. These are the neuroglucopenic symptoms caused by glucose deprivation in the central nervous system. These can range from dizziness, headache, and difficulty concentrating to more severe symptoms like confusion, slurred speech, abnormal behavior, progressing ultimately to seizures and coma if untreated. A particularly dangerous situation arises when patients, often due to recurrent episodes of hypoglycemia or long-standing diabetic neuropathy affecting autonomic nerves, lose those early sympathetic warning signs. This is called hypoglycemic unawareness, and it dramatically increases the risk of severe episodes occurring without warning.
How is hypoglycemia treated, especially in an emergency setting when someone might be confused or unconscious?
Treatment must be immediate and depends on the severity and the patient's ability to self-treat. For mild to moderate cases where the person is conscious and able to swallow, taking 15 to 20 grams of rapidly absorbed oral glucose is the standard. This could be glucose tablets, juice, regular soda, or even sugar packets. For severe episodes where the patient is unconscious, unable to swallow, or having seizures, giving anything by mouth is dangerous due to aspiration risk. In this situation, the standard medical treatment is an intravenous injection of 30 to 50 milliliters of 50% glucose solution, dextrose. If 5e access is difficult or unavailable in an out-of-hospital setting, an injection of glucagon, typically 0.5 to 1 milligram given intramuscularly or subcutaneously, can be administered by a family member or bystander. Glucagon works by stimulating the liver to rapidly release stored glucose, glycogenolysis. It's an expedient measure that buys time, but it only works if the patient has sufficient glycogen stores in their liver, which might not be the case after prolonged fasting or previous severe hypoglycemia.
Okay, moving from low sugar to the other extreme emergency, diabetic ketoacidosis, or DKA. This is predominantly seen in type 1 patients, often triggered by stress, like an infection, or simply inadequate insulin dosing.
DKA really represents the ultimate metabolic consequence of profound insulin deficiency coupled with excess counter-regulatory hormones. As we discussed, the absolute lack of insulin drives two major pathological processes simultaneously. Severe hyperglycemia, due to increased liver glucose production and decreased peripheral uptake, and massive, uncontrolled production of ketone bodies by the liver. The hyperglycemia leads to osmotic diuresis, excessive urination, trying to get rid of the sugar, causing profound dehydration and electrolyte loss. The massive accumulation of acidic ketone bodies overwhelms the body's buffering capacity, leading to severe metabolic acidosis. The combination of dehydration, acidosis, electrolyte imbalance, and hyperglycemia ultimately results in a potentially fatal coma if not treated aggressively and correctly.
And the treatment protocol for DKA is very precise and sequential, isn't it? It's not just about giving insulin.
It is highly rigorous and involves addressing multiple problems simultaneously. There are three main pillars. First, insulin replacement. Critically, we use regular insulin given intravenously, typically an initial IV bolus dose, around 0.1 to 0.2 units per kilogram body weight, is followed by a continuous low-dose infusion around 0.1 a kR. The goal is gradual reduction of blood glucose and suppression of ketogenesis. Second, aggressive fluid replacement is paramount to combat the severe dehydration and hypertonicity. We usually start with large volumes of isotonic normal saline, 0.9% ACL. We continue saline until blood pressure stabilizes and urine output improves. Then, typically when the patient's blood glucose level drops to around 250-300 milligil, we switch the IV fluid to 5% glucose, dextrose, and half normal saline, 0.45% ACL. Adding glucose at this point seems counterintuitive, but it's crucial to prevent too rapid a fall in blood glucose, which can cause cerebral edema, and also allows us to continue the insulin infusion to fully resolve the ketosis while providing substrate to replete depleted hepatic glycogen stores.
And the third pillar is critical electrolyte management, particularly potassium. Why is it so important to replace potassium, even if the initial blood tests might show normal or even high serum potassium levels?
This is a absolutely life or death clinical decision point in DKA management. You're right, the initial serum potassium level can be deceptively normal or high. This is because the severe acidosis forces potassium ions to shift out of the cells and into the bloodstream in exchange for hydrogen ions. Also, dehydration concentrates the serum potassium. However, the patient's total body potassium stores are usually severely depleted due to urinary losses during osmotic diuresis. When we institute insulin therapy, two things happen. Insulin directly drives potassium back into the cells, and correction of the acidosis also causes potassium to shift intracellularly. This combination can lead to a rapid and potentially fatal drop in serum potassium levels, hypokalemia, which can cause cardiac arrhythmias. Therefore, even if the initial level is normal, we typically start adding potassium chloride, KCl, maybe 10 to 20 milliequivalents per hour to the IV fluids relatively early in the treatment, usually once urine output is established and the serum potassium level starts to fall or is in the normal range. Close monitoring is essential. Sodium bicarbonate to correct the acidosis is generally avoided unless the arterial pH is critically low, typically below 6.9 or 7.0, because it can exacerbate hypokalemia and potentially worsen cerebral edema. Correcting the dehydration and ketosis with fluids and insulin usually resolves the acidosis adequately.
How does DKA compare and contrast with the other hyperglycemic emergency, the hyperosmolar hyperglycemic state, or HHS, sometimes called hyperosmolar non-ketotic coma, HONK? This is more often seen in elderly type 2 patients, right?
Yes, HHS is distinct from DKA, though both are life-threatening. HHS typically occurs in older individuals with type 2 diabetes, often precipitated by an illness or infection that leads to dehydration. The key features are extreme hyperglycemia, often much higher than in DKA, sometimes over 600 mg/dL or even 1,000 mg/dL, and consequently very high serum osmolality, usually above 320 mosmol. The severe hyperosmolarity leads to profound dehydration and significant mental status deterioration, often progressing to coma. The crucial difference from DKA is that significant ketoacidosis is usually absent or minimal in HHS. Why? Because type 2 patients still produce some endogenous insulin, usually just enough to suppress rampant ketogenesis, even though it's not enough to prevent severe hyperglycemia. Treatment principles overlap but have key differences. Fluid replacement needs to be even more aggressive in HHS due to the typically more profound dehydration. Because they have some residual insulin sensitivity and less acidosis, the required dose of exogenous insulin is generally lower than in DKA. Potassium replacement is still necessary, but often less aggressively than in DKA. Alkali therapy bicarbonate is almost never needed, one critical difference. Due to the extreme hyperviscosity of the blood caused by severe dehydration and hyperglycemia, patients with HHS have a very high risk of developing blood clots, thrombosis. Therefore, prophylactic anticoagulation, usually with heparin, is often recommended as part of the standard treatment.
Okay, let's briefly revisit insulin resistance from a management perspective since it really underpins the entire pathology of type 2 diabetes. How do we define it in this context?
From a clinical and therapeutic standpoint, insulin resistance is essentially a state where the target tissues, primarily the liver, skeletal muscle, and adipose tissue, exhibit a suboptimal biological response to physiological amounts of insulin. The signal isn't getting through properly. The sources consistently highlight the key factors that promote or worsen insulin resistance. Advanced age is one. A sedentary lifestyle is another big one. But arguably the most important modifiable factor is obesity, particularly visceral or abdominal obesity. The data strongly suggests that enlarged fat cells, adipocytes, become dysfunctional and contribute to systemic resistance, perhaps partly due to having fewer or less responsive insulin receptors and also by releasing inflammatory mediators. Polycystic ovary syndrome, PCOD, is also strongly associated with insulin resistance. It's also important to remember that acute insulin resistance can occur transiently. During times of significant stress, infection, or trauma, the body releases counter-regulatory hormones, cortisol, adrenaline, glucagon, that directly oppose insulin's action, causing temporary hyperglycemia. Even during DKA itself, the high levels of circulating ketones and free fatty acids can actually inhibit glucose uptake into muscle, contributing to the hyperglycemia. Management of acute resistance focuses on quickly treating the underlying precipitating cause, like the infection, and often requires temporarily administering higher doses of regular insulin to overcome the resistance.
Perfect. Now, armed with that understanding of insulin action, resistance, and deficiency, we can transition into the comprehensive arsenal of oral antidiabetic drugs, or OADs. These are primarily used for type 2 DM, and they are almost entirely defined by their specific mechanism of action, targeting the different facets of type 2 pathology we've discussed.
Exactly. The sheer diversity of these drug classes really reflects our evolving understanding of type 2 diabetes and the need to target multiple defects simultaneously: issues with insulin secretion, problems with insulin resistance, and even defects in the incretin system.
Let's start with the oldest class, the workhorses for many years, the insulin secretagogues. These directly stimulate the pancreas to release more insulin. We have to begin with the sulfonylureas, or SSUs.
Right. The sulfonylureas were among the first effective oral agents. They function essentially as pharmacological mimics of ATP at the ditocell K+ ATP channel. They bind specifically to the SUR1, sulfonylurea receptor 1 subunit of that channel complex. This binding forces the K plus ATP channel closed, independent of ATP levels. Just like when ATP closes the channel naturally, this leads to membrane depolarization, calcium influx, and ultimately the release of insulin from the beta cell. SUs primarily augment the second phase of insulin secretion, the sustained release, rather than the initial rapid spike. They are generally highly efficacious at lowering blood glucose. However, their major and potentially dangerous drawback is the risk of causing hypoglycemia. Because they stimulate insulin release regardless of the prevailing blood glucose level, the hypoglycemia can be severe, prolonged, and unpredictable. This risk is particularly high with the older, more potent, longer-acting SUs like glibenclamide, also known as gleburide. Interestingly, there's also evidence for some extra pancreatic action with chronic SU use. They seem to gradually sensitize peripheral tissues to insulin over time, perhaps by helping to reverse the receptor downregulation caused by chronic hyperglycemia, but their main action is definitely stimulating secretion. The shorter-acting SU, tolbutamide, carries the lowest risk of prolonged or severe hypoglycemia among the class.
And then we have the newer related class of secretagogues, the meglitinides, like repaglinide and the diphenylamine analog, nataglinide. They share that K plus ATP blocking mechanism, but seem to have a different practical application, right?
Yes, they were specifically designed for speed and a shorter duration of action compared to most SUs. They also bind to the K plus ATP channel complex, though perhaps at a slightly different site than SUs, and block potassium outflow, triggering insulin release. The key difference is their pharmacokinetic profile. They have a very rapid onset of action and, crucially, a much shorter duration of action. This makes them ideally suited for taking immediately before a meal, sometimes called prandial glucose regulators. Their purpose is specifically to target the sharp postprandial glucose spike after eating. Antidiabetic, in particular, is known for being especially fast and is thought to principally stimulate the crucial first phase of insulin secretion, which is often deficient in type 2 diabetes. Because they are rapidly absorbed and rapidly cleared from the body, they carry a significantly lower risk of causing delayed or prolonged hypoglycemia between meals or overnight, compared to the longer-acting sulfonylureas.
Okay, moving away from stimulating secretion, the next major category targets the root cause of type 2 in many patients, the insulin sensitizers. These drugs help the body use its own insulin more effectively. We absolutely must begin here with metformin, arguably the cornerstone, the undisputed foundational drug for type 2 diabetes.
Metformin, which is a biguanide, holds a truly unique and central place in type 2 diabetes management. It is almost universally recommended as the first-choice drug for virtually all newly diagnosed type 2 patients, unless contraindicated. A key feature is that it's considered euglycemic rather than hypoglycemic, meaning when used as monotherapy, it lowers elevated blood glucose, but does not typically cause hypoglycemia because it doesn't actively stimulate insulin secretion from the beta cell. Its primary mechanism of action is complex and still not fully elucidated, but it centrally involves the activation of an enzyme called AMP-dependent protein kinase, or AMPK. AMPK acts as a crucial cellular energy sensor.
And what are the main resulting clinical benefits of activating AMPK with metformin?
The major therapeutic action, the one responsible for most of its glucose-lowering effect, is the suppression of hepatic gluconeogenesis. It significantly reduces the liver's excessive production and output of glucose, which is a key driver of fasting hyperglycemia in type 2 diabetes. Secondarily, metformin also enhances insulin-mediated glucose uptake and utilization in peripheral tissues, particularly skeletal muscle and, to some extent, fat. It directly helps overcome insulin resistance at the tissue level. Clinically, beyond just lowering glucose, metformin often promotes modest weight loss, or at least weight neutrality, which is a significant advantage over many other agents like SUs or insulin that cause weight gain. But most critically, metformin is the only oral antidiabetic drug that was definitively demonstrated in the landmark UK prospective diabetes study, UK-PDS trial, to significantly reduce not only microvascular complications like retinopathy and nephropathy, but also macrovascular complications, including diabetes-related death, heart attack, MI, and stroke, particularly in overweight patients, followed over the long term. This macrovascular benefit is huge.
That macrovascular benefit is key. Given that it's excreted unchanged by the kidneys, why is renal function such a crucial consideration and contraindication?
That's right. Metformin is not metabolized by the liver. It's excreted entirely unchanged by the kidneys through tubular secretion. If renal function is significantly impaired, usually defined by the low estimated glomerular filtration rate, eGFR, the drug cannot be cleared effectively and can accumulate in the body. This accumulation dramatically increases the risk of a rare but potentially life-threatening side effect called lactic acidosis. While the absolute risk is very low in patients with normal renal function, it becomes unacceptable if kidney function declines significantly. This absolute necessity for adequate renal clearance restricts its use in patients with moderate to severe chronic kidney disease. It's also generally contraindicated in conditions predisposing to hypoxia or acidosis, like severe heart failure or heavy alcohol abuse. But despite these limitations, its proven efficacy, low cost, weight benefits, and particularly those unique macrovascular outcome benefits, solidify its position as the undisputed first-line agent.
Okay, the second major group of insulin sensitizers is the thiazolidinediones, or TZDs. The main one still in use is pioglitazone. They work through an entirely different cellular receptor mechanism, don't they?
Yes, the TZDs operate through a completely different pathway compared to metformin. Pioglitazone is a selective agonist for a nuclear receptor called PPA-gamma, that's peroxisome proliferator activated receptor gamma. PPA-gamma is found predominantly in adipose fat cells, but also in muscle and liver cells to some extent. Activation of this nuclear receptor acts like a transcription factor, leading to changes in the expression of a whole host of genes involved in glucose and lipid metabolism, and importantly, in adipocyte differentiation and function. The net effect is a significant improvement in insulin sensitivity. They reverse insulin resistance primarily by increasing the transcription and subsequent translocation of those GLUT4 glucose transporters, especially in fat and muscle. They also help suppress excessive hepatic glucose production. Clinically, besides lowering blood glucose, pioglitazone also has some potentially favorable effects on the lipid profile. It tends to lower serum triglycerides and raise HDL cholesterol, the good cholesterol.
But TZDs, historically and currently, come with some significant risk management challenges and baggage.
They absolutely do, and this has significantly limited their use compared to metformin. A major side effect is fluid retention, leading to plasma volume expansion, peripheral edema, swelling, and often weight gain. Crucially, this fluid retention means they carry an increased risk of precipitating or worsening heart failure. Hence, they are strictly contraindicated in patients with established congestive heart failure, CHF, typically New York Heart Association Class 3 or 4. They are also generally contraindicated in patients with active liver disease. Additionally, long-term use, particularly in postmenopausal women, has been associated with an increased risk of bone fractures, likely due to effects on bone metabolism. There were also earlier concerns about a potential link between pioglitazone and bladder cancer, although large long-term studies have been somewhat reassuring but haven't completely eliminated the concern. So, while effective sensitizers, they must be used judiciously, often reserved for patients with significant insulin resistance who haven't responded adequately to or cannot tolerate metformin, and only after careful consideration of the risks and benefits, especially regarding cardiovascular and bone health.
Right. Okay, next we arrive at arguably the newest major area of innovation in OADs, drugs that modulate the incretin system, leveraging that gut-pancreas communication pathway we discussed earlier.
Exactly. The key physiological insight here was realizing how rapidly the body degrades the native incretin hormone GLP-1 using an enzyme called dipeptidyl peptidase 4, or DPP4. GLP-1 has a half-life of only a couple of minutes in circulation. This understanding led directly to the development of two distinct but related and highly successful classes of drugs aimed at either preserving the action of endogenous incretins or mimicking GLP-1 action directly.
Let's start with the direct mimics, the GLP-1 receptor agonists such as exenatide, liraglutide, semaglutide, and others.
These are typically injectable medications, though an oral form of semaglutide now exists. They are synthetic analogues of human GLP-1, but they've been engineered to be resistant to degradation by that DPP4 enzyme, giving them a much longer duration of action than native GLP-1. They work by binding directly to and activating the GLP-1 receptor, primarily found on pancreatic beta cells, but also in other tissues like the brain and gut. This activation powerfully amplifies the natural incretin effect. Specifically, it stimulates glucose-dependent insulin release from the beta cells. The glucose-dependent part is key, meaning they primarily stimulate insulin release only when blood glucose levels are high, thus carrying a very low intrinsic risk of causing hypoglycemia when used alone. They also suppress the secretion of glucagon from pancreatic alpha cells, which helps lower liver glucose production. slow down gastric emptying, which reduces post-meal glucose absorption, and acts centrally in the brain to promote satiety and suppress appetite. The key clinical benefits derived from these actions are not just effective glucose lowering, but also significant weight loss in many patients, and increasingly strong evidence for cardiovascular risk reduction, particularly with agents like liraglutide and semaglutide. However, they do have drawbacks. Gastrointestinal side effects, particularly nausea and sometimes vomiting or diarrhea, are quite common, especially when starting therapy, affecting up to 50% of recipients in some studies, though tolerance often improves over time. There have also been concerns, although causality isn't definitively proven, about a potential small increased risk of acute pancreatitis with this class. Liraglutide and semaglutide are noteworthy for their longer half-lives, allowing for convenient once-daily or even once-weekly injections, respectively.
Okay, so that's mimicking GLP-1. The second approach is the oral alternative. The DPP-4 inhibitors like sitagliptin, vildagliptin, saxagliptin, linagliptin. How do they work?
These drugs, often called gliptins, take an indirect approach. They are competitive, orally active inhibitors that specifically block the action of the DPP-4 enzyme throughout the body. By inhibiting DPP-4, they prevent the rapid breakdown of the body's own endogenous incretin hormones, primarily GLP-1 and GIP. This effectively increases the levels and prolongs the activity of naturally secreted incretins. Their advantages are quite clear. Like the GLP-1 agonists, they enhance insulin release in a strictly glucose-dependent manner, resulting in a very low risk of hypoglycemia when used as monotherapy. They are generally body weight neutral, which is better than SUs or insulin. Some studies suggest they might have beneficial effects on preserving the beta cell function over time. They are convenient oral medications taken once daily. And importantly, agents like sitagliptin and linagliptin, which have different primary routes of excretion, renal versus biliary, offer viable options, sometimes with dose adjustment, even for patients with significant renal impairment, where metformin might be contraindicated. However, their overall glucose-lowering efficacy is generally considered moderate, perhaps slightly less potent than metformin or SUs. Common side effects include things like nasopharyngitis, common cold symptoms, headache, and occasionally cough. There have also been rare reports of allergic reactions, joint pain, and that persistent, though low, background concern about pancreatitis, similar to the GLP-1 agonists. Some studies with certain DPP-4 inhibitors also raise concerns about a potential increased risk for heart failure hospitalizations, although this doesn't seem to apply to all drugs in the class.
All right. Finally, we have two other distinct mechanisms rounding out the OAD arsenal. First, the alpha-glucosidase inhibitors. These seem less common now.
Yes, acarbose and miglitol work entirely within the gut. They reversibly inhibit the alpha-glucosidase enzymes located in the brush border membrane of the small intestine. These enzymes are responsible for breaking down complex carbohydrates, like starches and sucrose, into simpler, absorbable monosaccharides, like glucose. By inhibiting these enzymes, acarbose slows down the digestion and subsequent absorption of carbohydrates from a meal. Their effect is solely focused on modestly reducing the postprandial rise in blood glucose. They have little effect on fasting glucose. However, their major limitation, and the reason they aren't widely used despite being effective for post-meal spikes, is extremely poor patient acceptability. Because they leave undigested carbohydrates to pass into the large intestine, these carbs get fermented by gut bacteria. This fermentation process commonly causes significant and often socially embarrassing gastrointestinal side effects, such as flatulence, bloating, abdominal cramps, and sometimes loose stools or diarrhea. Many patients simply can't tolerate them long term.
And the last major class, perhaps the most revolutionary in recent years, the SGLT2 inhibitors. These work in a completely novel way, right in the kidney.
Absolutely. Drugs like dapagliflozin, canagliflozin, empagliflozin, the Flowreas, represent a completely different approach, independent of insulin action or secretion. They work by specifically blocking the sodium glucose cotransporter 2, or SGLT2, which is located primarily in the proximal convoluted tubules of the kidney nephrons. This SGLT2 transporter is responsible for reabsorbing the vast majority, nearly 90% of all the glucose that gets filtered by the glomeruli back into the bloodstream. By inhibiting SGLT2, these drugs effectively block this reabsorption process, forcing large amounts of excess glucose to be excreted out of the body in the urine, a process called glucosuria. They essentially make you pee out sugar. The benefits are significant. They lower blood glucose effectively, independent insulin levels, or beta cell function. Because they remove calories as glucose, they promote weight loss. And since their action doesn't involve stimulating insulin, they carry essentially no intrinsic risk of causing hypoglycemia. Furthermore, large cardiovascular outcome trials, particularly with empagliflozin and canagliflozin, have shown remarkable benefits beyond glucose control, including significant reductions in hospitalization for heart failure and progression of chronic kidney disease, making them incredibly valuable agents, especially in patients with established cardiovascular or renal disease. However, they do have specific risks. By forcing sugar into the urinary tract, they significantly increase the risk of developing urinary tract infections, UTIs, and genital mycotic infections, yeast infections, particularly in women. They can also cause osmotic diuresis, leading to volume depletion, dizziness, or postural hypotension, especially in the elderly or those on diuretics. There's also a rare but serious risk of euglycemic DKA occurring with relatively normal blood glucose levels, particularly if patients become ill or stop eating. And importantly, they are generally contraindicated or require dose reduction in patients with significant renal insufficiency because their glucose-lowering efficacy depends entirely on the kidney's ability to filter glucose in the first place.
Wow, that is a phenomenal arsenal of tools. This brings us neatly to clinical management strategy. Based on all this pharmacology and decades of clinical evidence, what are the accepted treatment goals, and what's the current standing or hierarchy of these OADs?
Right. The consensus goals for what constitutes adequate glycemic control, aiming to minimize long-term complications, are generally maintaining fasting blood glucose levels, ideally between 90 and 130 milligdl, keeping 2-hour post-meal blood glucose levels below 180 milligdl, though some guidelines aim for 150 milligdl, and critically, achieving and maintaining the long-term average index, HbA1c, below 7%, although for some patients, a slightly higher or lower target might be individualized.
And the relative standing and safety profile of these drugs, particularly the older ones like SUs and Metformin, was dramatically shaped by that massive UK prospective diabetes study, UKPDS, wasn't it? It really resolved major controversies from earlier, smaller trials.
The UKPDS, published back in 1998, but with long-term follow-up data still emerging, was absolutely definitive and changed practice worldwide. Firstly, it clearly established that intensive glucose control with either sulfonylureas or insulin was safe in the long term and did not increase cardiovascular mortality, effectively refuting concerns raised by the much earlier UGDP study from the 1970s. But the truly critical finding came from the long-term outcome analysis, comparing different treatment strategies. It found that while intensive control with either S-use or insulin significantly reduced the risk of microvascular complications, like retinopathy requiring laser treatment or worsening nephropathy, it was only the group randomized to intensive control with metformin, specifically the overweight subgroup, that showed a significant reduction in macrovascular complications, including overall diabetes-related death, myocardial infarction, heart attack, and stroke compared to conventional therapy.
That specific distinction, metformin providing macrovascular protection, whereas insulin didn't in that trial, that fundamentally alters the treatment hierarchy, doesn't it?
It absolutely does. That finding, coupled with metformin's favorable profile regarding weight and hypoglycemia risk, is why it became the undisputed first-line agent. The prevailing hypothesis is that metformin's benefit extends beyond just lowering glucose. It's attributed more to its fundamental role in improving the underlying metabolic machinery, specifically by overcoming insulin resistance and perhaps having direct beneficial effects on the vasculature, rather than simply forcing the already stressed pancreas to produce more insulin, as used to do. So current guidelines from major diabetes organizations worldwide consistently recommend metformin as the initial first-choice pharmacological therapy for virtually all patients diagnosed with type 2 diabetes right from the start, alongside lifestyle modification, unless there's a specific contraindication or intolerance. This is particularly emphasized for obese or overweight patients due to those demonstrated macrovascular benefits and its favorable weight profile.
Okay, so metformin is king of the hill to start. What happens when, inevitably, for many patients as type 2 progresses, metformin alone isn't enough to keep HbA1c below that 7% target? How do we choose the second drug to add?
That's the common clinical scenario. If HbA1c remains above target despite metformin monotherapy and lifestyle efforts, a second agent needs to be added. The choice here becomes more nuanced and depends on individual patient factors, comorbidities, cost, and side effect profiles. Traditionally, sulfonylureas were often the go-to second-line agent due to their high efficacy, long history of use, and low cost. However, their significant downsides, the risk of weight gain and hypoglycemia, and the concern that they might contribute to eventual beta cell exhaustion have made them less favored as an automatic choice now. The modern approach often prioritizes adding one of the newer classes next, depending on the patient's specific needs. For instance, if avoiding hypoglycemia and keeping weight neutral are key priorities, adding a DPP-4 inhibitor is an excellent, well-tolerated choice. If the patient has significant residual insulin resistance, or if cost is a major issue and hypoglycemia risk can be managed, pioglitazone might be considered, carefully weighing its risks. Increasingly, if the patient is obese or overweight and needs help with weight reduction, or especially if they have established atherosclerotic cardiovascular disease or heart failure or chronic kidney disease, adding a GLP-1 receptor agonist or an SGLT2 inhibitor is now strongly recommended as second-line therapy due to their proven benefits in these specific areas, often even independent of their glucose-lowering effect. The guidelines are becoming much more stratified based on comorbidities.
That makes sense. Finally, before we wrap up, we should probably briefly touch upon glucagon again, not just as a treatment for hypoglycemia, but as the critical counterhormone to insulin in the bigger picture.
Yes, glucagon deserves a mention in its own right. It's a 29 amino acid polypeptide hormone secreted by the alpha cells of the pancreatic islets. Physiologically, it's the primary counter-regulatory hormone to insulin, exerting effects that are generally opposite, meaning it's hyperglycemic. Its main action is in the liver, where it strongly stimulates both glycogenolysis, the breakdown of stored glycogen, and gluconeogenesis, the synthesis of new glucose. It's essentially the hormone of fuel mobilization, raising blood glucose during fasting or stress. Its secretion is normally inhibited by high glucose levels and by insulin, that paracrine effect we discussed, but it's stimulated by low glucose levels and also by amino acids, like after a high-protein meal, to prevent hypoglycemia from the insulin released in response to the protein.
And its clinical use, as we noted, is largely limited to that emergency rescue role.
Primarily, yes. Pharmacologically, synthetic glucagon is used almost exclusively as that expedient emergency treatment for severe hypoglycemia when giving oral glucose isn't possible and IV access is unavailable. It allows a trained family member or caregiver to quickly raise the person's blood sugar. We also see its essential, though pathological, role in the development of DKA. The combination of profound insulin deficiency and unopposed or even elevated glucagon levels is what really drives the runaway hepatic glucose production and ketogenesis seen in that state.
Okay, so what does this all mean? We've journeyed through an incredible amount of detail, from the atomic structure of insulin, the mechanical closing of a tiny potassium channel, right up to the massive public health impact revealed by huge trials like the UK PDS. It feels like the real mastery here lies in seeing just how interconnected all these systems truly are.
I think that's exactly right. If you're aiming for mastery in this field, the critical takeaways are really manifold. First, always remember that the devastating long-term pathology of DM is driven by specific molecular changes, non-enzymatic protein glycosylation, and that secondary sorbitol accumulation pathway. That's why monitoring HbA1c isn't just about a number, it's about tracking the underlying damage process. Second, appreciate the incredible multi-layered complexity of insulin regulation. It's not just about glucose. It involves those K plus ATP channels, the powerful incretin hormone system, intricate paracrine feedback within the islet, and constant neuromodulation. Understanding these allows you to grasp how different drugs work. Third, recognize that modern insulin therapy has evolved specifically to try and correct physiological deficits. The move towards basal bolus regimens using long-acting and rapid analogues is all about mimicking natural insulin release patterns as closely as possible. And fourth, particularly for type 2, internalize why metformin remains the cornerstone of management. It's not just for lowering sugar numbers today, but for its unique, proven ability to reduce long-term macrovascular complications, likely by fundamentally addressing the core issue of insulin resistance.
That's a great summary. And maybe as a final provocative thought for our listeners to mull over, if much of the long-term devastation we worry about, the neuropathy, the retinopathy, maybe even nephropathy, is significantly rooted in that secondary sorbitol accumulation pathway we discussed right at the beginning, is the therapeutic challenge truly finished once we get the blood glucose numbers under control with insulin or OADs?
That really raises the crucial question of whether we should be targeting the collateral damage pathways more directly, shouldn't it? While we've focused heavily, and rightly so, on achieving glycemic control, targeting these secondary mechanisms could be a key frontier for improving long-term health outcomes, even in well-controlled patients. Consider, for instance, a drug class like the aldose reductase inhibitors. Ipirestat is an example used in some parts of the world. These drugs specifically inhibit that enzyme, aldose reductase, which converts glucose into sorbitol in those vulnerable tissues like nerves and the eye. By blocking this enzyme, the aim is to directly prevent the damaging intracellular accumulation of sorbitol, regardless of minor fluctuations in blood glucose. This approach highlights that true therapeutic mastery might eventually need to extend beyond just managing glucose levels. It could mean identifying and therapeutically inhibiting every significant pathological mechanism that operates downstream of hyperglycemia to more effectively delay or prevent devastating end organ damage entirely. It makes you think about where the next breakthroughs might come from, doesn't it?